Good morning and welcome to COVID-19 Talk with local health authorities. Joining us from Harris County is Dr. Erica Brown, the City of Houston, Dr. David Pearce. Special thanks to Kathy Fenninger, past president, Rotary Club of Houston, to our producers, David Castillo, Priscilla Key. I'm Stephen Williams, director of the Houston Health Department. Let's start off with status. Harris County threat level is now agreeing with COVID cases and hospitalizations down. What about COVID daily death numbers?
Yes, so when we transitioned to the reporting system similar to the CDC, we report our numbers on a weekly basis now, so I don't have daily numbers. Unfortunately, there are still people across the country and around the world who are dying from COVID, but certainly not as many as we previously had. So our numbers are not going up as rapidly as they previously were.
What's the incidence right now?
So that's hard to say because we have so many people who are testing at home, and we have a really tiny number by comparison of folks who are testing at our sites we get our numbers from. So it's almost impossible to say what the incidence rate is now. We are looking at the hospitalizations. It's a better indicator, and those are way, way down, fortunately. But and so we've got a metric up there about positivity rate and our wastewater. So the numbers are all moving in the right direction.
Just tell us a little bit about wastewater while you're talking.
Yeah, so the wastewater is down, as you can see there, to 48%, and that is a comparison to the July 6, 2020 value, which is the peak of the first wave. But we have been a little bit lower than this. My memory, I'd have to go look at it, but I think we were down to as low as 31% at one point since we started measuring the wastewater. But this is an extremely low number, and over the last couple of weeks, the week-over-week change has been pretty dramatic, like dropping by almost half per week. So yeah, the wastewater is dropping down. Now, we say that, but this is not the time for us to drop our guard. We're seeing, increasing rates of COVID in Northern Europe or across Europe. And I've heard at least one report that perhaps in Boston, they've seen their wastewater go up. So yeah, things are good right here in Houston for now, but don't count your chickens before they're hatched, as they say.
I'm supposed to be going to Boston next month for APHA, David, so maybe I should be mindful of that. BMJ Medicine published a story that vaccine could slightly alter a menstrual cycle. Is that true?
The data shows that it is potentially true, that immediately following, there may be a longer or a heavier menstrual cycle, but that it quickly returns to normal.
Okay. Is chronic COVID and long hauler symptom the same thing?
So, there's no real test for long COVID. And so right now, even the terminology is a little fudgy, if you will. So it depends on, who's talking, but you can probably consider them to be the same thing. So one thing is that when you say chronic, any chronic illness, it generally implies that it's a lifelong. Now, we've not necessarily seen that with COVID yet. So I've not used that term chronic COVID because in my mind, that usually means it's a lifelong thing. Like asthma is generally, for adults, it's generally a lifelong illness. That'd be chronic asthma as an example. So we haven't had COVID long enough yet to really call it chronic. But long haul, yeah, absolutely.
Okay, I mentioned this earlier. Cases in European countries are rising. Based on that, do you predict the decrease in cases here may reverse?
As David just said, don't count the chickens yet. We will see. Hopefully, if we can continue to get people vaccinated with the bivalent booster, we won't see so much of a rise, but it is very, very possible.
Vaccine myocarditis versus post-COVID myocarditis and pericarditis, which is worse? Do vaccines change the severity of numbers?
Yeah, so first let's talk a little bit about those terms, myocarditis and pericarditis. They are similar but different. Myocarditis is an inflammation of the heart muscle itself, and pericarditis is an inflammation of the pericardium, the sac that the heart sits in. They're both inflammatory, and we've seen them both, with people with COVID. And to answer the question is, in the cases where we've seen it as a result of vaccine, it has been generally in adolescent males. It's been short-lived, and with basic, simple supportive care, they largely do just fine and return to normal. people who get the myocarditis in particular from COVID infection often have more problems. Many of them resolve just fine, but there's a greater incidence of it with the illness as opposed to the vaccine, and it tends to be a little bit more complicated.
Now that we're at the beginning of a new school year, maskless, what is the prevalence in schools?
So fortunately, prevalence seems to be low. However, we can't forget that home testing, right? We don't necessarily have reports from home testing. What we think is happening is because there's been such a widespread throughout the community over the summer and things with Omicron in particular, perhaps we're getting some immunity that way as well. But fortunately, we're not seeing too much prevalence in the schools. But there, again, we can't account for the home testing portion as well.
Can you provide any update on Quadrivalent? Dr. Hotel seems to be getting beaten up on social media. What are they saying about it?
Yeah, I don't know. I don't do social media very much because it's, but so Quadrivalent is, it's being used largely in India. And the last time I looked, which is just a few days ago, it was I think over 7 million doses have been given. And they're finding very few problems with it, and it seems to be pretty highly effective. So I think the news is good about Quadrivalent. It's not quite, I think they've got their application in several other countries. I don't know where we stand with the FDA. I suspect they've got it in. It hasn't been approved here yet, but the early news out of India, which seems to be working just fine. So I feel bad for Dr. Cahotes.
Erica, you got any comments on that? Do you know what they're saying?
I don't know either. I don't really do social media either. I think she's been a great contributor throughout this entire pandemic.
Okay. Is long haul unrelated to age, race, or sex?
After the initial diagnosis, several factors seem to be associated with long COVID. And some studies are showing that unfortunately there is potentially relation to ethnicity, social vulnerability, and as well as insurance status, oddly enough. So it seems that these things may be related to, unfortunately, chronic disease. Of course, the data is still being researched, but there does seem to be some relationship.
And related to that, I think the next comment and question, post-COVID center shows Texas PCC shows city locations and specific focus. It shows only one location in the medical center that focuses on the heart. Some days I cannot get out of bed and have dragged myself to a neurologist, cardiologist, neuropsychologist, appointments all around town and a month apart, since it seems to have to do with your visits sequentially. This is year 2 and counting. When is the medical community going to focus more on this growing COVID impacted community, especially with the heart?
Yeah, I think that's a little difficult to answer, and I'm sorry to hear that you're having those symptoms. There are certainly long COVID clinics I am aware of at all the major medical centers, certainly in the TMC, although sometimes it's difficult to access just because of location. However, what I would suggest is if there's something specifically related to the heart, to certainly work through, if you are insured, work through your insurance for cardiology referral, which they then may lead to additional referrals into other long COVID perhaps programs, but certainly make sure that you are checking out any symptoms you may be having with the heart.
How common is brain fog and what are the manifestations? How is brain fog diagnosed and treated?
So brain fog is relatively common. So it's described as being sluggish or slow thinking, difficulty concentrating. And as it relates to COVID, we are seeing some prevalence of it, about 20 to 30% in patients who have been diagnosed with long COVID. It does often resolve with long COVID after several months or so, but treatment is really dependent on the diagnosis. There are other things that also unfortunately cause brain fog. A lot of chronic diseases can cause it as well. And so treatment of that chronic disease sometimes will resolve the issues as well.
My PCP tells me my CT scan shows pulmonary pleuropfibrosis. Is that pleurisy, mesothelioma? How is fibrosis treated? Y'all are getting the test today, aren't you?
It's like a blood exam, for crying out loud.
They're going to see whether you're real doctors. That's what it is, I think.
So earlier I talked about myocarditis versus pericarditis. I mentioned the heart sits in a sac called the pericardium, where the lungs sit in a sac. Similarly, it's called the pleura. And so pleurisy is a inflammation of the pleura, the exterior lining of the lung and the interior lining of the chest wall. So that's pleurisy. Mesothelioma is a form of cancer, and it can often be found in the pleura, but it can also be found elsewhere. The mesothelium is a type of tissue that's found throughout the body, but is often, when you hear about mesothelioma, it's a cancer found in the chest cavity. And then fibrosis is basically scarring of the lung tissue, generally due to some either a chronic illness or a previous infection. And unfortunately, because it is a scarring, there's no great way to reverse it. Patients are often treated with ways to improve your lung function in spite of the fibrosis, but there's no great way to reverse that scarring once it occurs, unfortunately.
The more I hear y'all discuss this and with these questions, it inspires me to ensure that I'm up to date on my vaccinations. On the last, huh? Yeah, it's a little scary. On the last program, you had a great discussion, a great session on complications of COVID, including long haulers. Could you, into greater depth, as a great deal of confusion, any news you can share? Y'all have had, I think, a continued discussion on this, but anything else you want to maybe summarize?
So I wasn't on the last meeting because I was on vacation. So congratulations to Dr. Brown and Dr. White for having had such a great conversation. All I'll say about post-COVID is a little bit of what I've already said. It's very difficult to diagnose. It's, generally people are infected, will have COVID-19 disease. They'll get better within about a few weeks, right? Generally 2 weeks or 3 weeks maybe. So the long haul symptoms are generally not considered to be long haul until they are persistent or they start up after 4 weeks from your initial illness. There is growing expertise in this because we do have some clinics where there are, where patients with long haul are being evaluated and cared for by doctors, but it is post-viral illness is not a new phenomenon, but with COVID, because most viruses will infect, like you get a cold virus, it pretty much infects your nose, right, and your upper airway passage. Lung tends to be more pulmonary, although not viral, but a strep throat or so, there's a bacteria, it's your lungs, right? So most pathogens tend to infect one organ system generally. Meningitis goes to the meninges in the brain. COVID, it can impact any organ system. We've seen skin, eye, heart, intestines, lungs, blood vessels, blood itself and its clotting factors. So the thing about COVID that makes it so different is that it seems to be able to impact each and every organ system, which most viruses and bacteria don't do. So it is a growing area of new expertise. And I was part of the previous conversation. So I don't know, maybe Dr. Brown, you should go more. You know how in depth you went last time. Maybe there's something that you could add. I don't know.
The sad part about it is I don't remember how deep we went.
He has brain fog.
Right, exactly. I have a virus right now and I am truly in fog.
The next question, actually, I think y'all have covered this, and that was exactly what is encompassed by the term chronic COVID, and you explained that earlier, I think. Okay, we're going to move on a little bit. Vaccine side effects. After 4 Pfizer shots with no reaction, the bivalent effect of substantial swelling at the shot location that lasted for a number of days. What might that be?
So injection site swelling is a very common side effect of any vaccine. And so it could have happened with any of the COVID-19 vaccines that you receive. It's not specific to the booster. So the best I can say is that it's a known reaction to any vaccine, including the COVID vaccines.
What is quadrivalent? Texas already is in flu season. Is this early?
Yeah. So quadrivalent means that the vaccine, the flu vaccine, actually is providing protection against 4 different types of influenza virus. So when we talk about with COVID, the bivalent, that means that there's, 2 forms of virus are you're getting protection from 2 forms of the virus, 2 mutants. So quadrivalent means that there's 4, and to have, I'll say, multivalent vaccines is not necessarily new. In fact, the flu vaccine for years has been multivalent with 2, 3, or 4 versions of the flu virus, giving you protection from 4 of those in the shot. 4 is a fairly high number, but 2 or 3 is very, very common.
Okay, and I saw Priscilla actually put some stuff up to support that. FluMist for those under 50, good, bad? Why only below 50?
Yeah, so anytime medications and vaccines are considered under medications, right, for FDA approval, there's research done to show what's the most effective route of transmission. So FluMist is a nasal version of the flu vaccine. It has been shown to be effective for those between the ages of 2 and 49. So the data showed that those above 50, it may not have as much efficacy. And so that's why it's recommended for those ages 2 to 49. It is effective though. And so again, for those who meet the eligibility criteria, certainly is a good option.
Australia has high flu. Should we take that as a predictor?
Yeah, we should. So the flu virus circumnavigates the globe every year, northern hemisphere, then southern hemisphere, and then back to the northern hemisphere. And in fact, it is the virus that is circulating in the southern hemisphere that the pharmaceutical companies use to create the vaccine that we will get, because it usually is similar. Although, every year it changes a little bit as it goes around. So the flu virus mutates just like COVID does. And so they take what's circulating in the southern hemisphere. But we've also seen that when the southern hemisphere has a bad flu year or a soft flu year, we tend to be similar. Now this year, it's going to we have lots of reasons to anticipate a difficult flu. Not only did Australia have a more difficult flu season than usual, but the last 2 years we've been wearing masks, we've been social distancing, we've been washing our hands. The flu vaccine uptake hasn't been what we would like it to be, but because people are doing all those other things, we have really, really mild flu years. So what that has now created is that as a population, we have less herd immunity to the flu, because some of the people who would have gotten infected over the last 2 years would have some residual immunity because of their previous infection. They don't have that now, right? So we have about the same amount of influenza vaccination rates that we usually have, in fact, a little bit lower with all the anti-vax talk that's going on, but we have no residual herd immunity from infections over the last 2 years. So, we are at risk for a potentially bad flu year. And the other thing I want to point out is that this will be a really bad year for somebody to get the flu and require hospitalizations. The hospitals have not recovered from COVID. We're seeing restaurants back online. We're seeing entertainment, professional sports, all these other things of society are coming back and recovering, but the hospitals have not, and they have not recovered because of the nursing shortage. So we have lots of hospitals in our community that have got empty wings, not because, they got beds there, but they don't have the nurses to staff them. So this is, as we're entering into this flu season and with the potential for another wave of COVID coming, as we're seeing in Europe, this is, I'm a little anxious about what we're going to have come, November, December, January here in Houston in terms of hospital capacity. So, anybody who's watching this, if you haven't got your flu shot, if you haven't got your bivalent shot, you need to go get them now.
Okay, let's go over to a Halloween alert. Rainbow candy, fentanyl lace candy, and chalk. Is that for packed or just loose candy? That no one should be taken from strangers.
So I think that obviously this is a really unfortunate trend. And some of the precautions that we would normally take really apply here to talk to your children about not taking anything from strangers, not taking anything that is loose, or for instance, this reminds me of sweet tarts and Skittles, those kinds of things. Um, and really having unfortunately a serious conversation and actually showing the pictures. Just a little anecdote. My youngest is a teenager, and I did literally show this picture to him and advise him this is what it looks like. It's not candy, and I wasn't trying to scare him, but I let him know you can die.
Mhm.
At the same time, again, it is Halloween season. We hope to have a safe Halloween season. I am sure the kids will be out. I know in my neighborhood, I guess because people feel like we're moving out of COVID. People in my neighborhood decorations have been up since September. So people are excited this year. So I expect a record turnout for Halloween, just as we would normally do. Take precautions and inspect the candy. If it's loose candy, I would highly suggest you throw it away, just for sanitary reasons as well. And the best we can do is really have conversations with our children, and let them know that these are some serious threats, unfortunately.
That is unfortunate. What is a hyperactive immune system?
Yeah, so hyperactive immune system is basically what it sounds like. You can think of sometimes as an allergic reaction being a form of a hyperactive immune system. Your body gets exposed to a pathogen, whether it be a virus or a bacteria, or perhaps just dust or dander or pollen, or something that you eat. And your immune system, which is designed to know what is you and what is not you, recognizes this is something which is not supposed to be here. But instead of either tolerating it or managing it under normal conditions, it overreacts. And it's a little bit different from one person to the next, but you can get a variety of symptoms. You can get blood vessel dilation. You can get hypersecretion into your airways and into your lungs. You can get, intestinal problems. But the life-threatening ones are really the respiratory ones. When the blood vessels dilate, they become leaky. The fluid in the blood, the plasma part of it, the watery part of it, starts leaking out into the tissue around it, causing swelling. And that can happen in a variety of different organ systems. But that's basically your hyperactive immune system syndrome.
Okay, alphabet COVID. Who comes up with these? Is BA 4.6 increasing? BQ1, BQ 1.1 as offshoots of BA5? Do they evade vaccine? Is that the same as XBB antibody evasive strain 2.75.2? My Lord.
Okay, I'm going to try to be succinct and thorough in a short time period. So there are absolutely a lot of circulating variants. Speaking to some of the questions we had previously about what they're seeing in Europe, there's no question about that. However, here, still the most prevalent variant is BA5. The best thing that we can do right now with the most prevalent variants is to get our COVID booster, which is a combination of BA4, BA5, and the original strain. Okay, that is truly the best thing we can do to protect ourselves. Are there other variants circulating, including BA6, which is replacing BA4, and BQ11, and all these others coming along? Absolutely. But right now, as we've discussed before, they are not an imminent threat to us because of the level at which they're spreading. And certainly, one of the things that I can't stress enough is I really do believe this, and let me say this, once you try to predict something, as David said, right, it always is the opposite. But I really do believe that this is going to become something similar to the flu, where every year we have some variants and we take a look back at the previous years to see what was most prevalent. And perhaps that is what our vaccines may be made of. If we get to the point where COVID vaccine becomes a routine part of our vaccine series, So for now, we're going to see variants. We're going to see a whole bunch more alphabets and maybe some more Roman numerals come into play as well. And it's just something that we're going to continue to monitor. But for now, we are still BA.5 is the most prevalent for us. And the best thing you can do to protect yourself is to get the booster.
Okay. Minnesota Department of Health discovered the monkeypox virus has mutated. Does that impact treatment?
Yeah, so what they found in Minnesota was actually pretty interesting. They found that there were, with their sequencing in one of their labs, and we have many labs across the country that are doing this, they're sequencing the entire genome periodically, random sampling. And what they found in Minnesota was they found a couple of variants where a whole segment of the RNA were either missing or they had just been switched around in the order. And these are, so we talk about point mutations where one amino acid gets swapped out for a different amino acid. And then you get these, segmental ones where they're either missing or they're swapped around. And we also worry about getting segments swapped out with other viruses, right? And so there's all kinds of things. Now, the one thing about COVID that people need to understand is it is an RNA virus, so it is a single strand. So its capacity to mutate is much greater than, for example, monkeypox, which is a DNA virus, and it's double-stranded. And so mutations in DNA viruses are far more difficult and less common. And so this is because COVID is an RNA. That's why we've seen so many mutations and all the alphabet soup. And hopefully, this will slow down a little bit so that, like Dr. Brown is predicting, hopefully we'll have one highly effective vaccine per year and the number of mutations slow down. But we're gonna have to wait and see because RNA can easily mutate.
Healthcare workers are continuing to leave their profession at alarming rates. Are we ready in Houston if there's another surge?
We are. So I think David addressed this already. Unfortunately, healthcare workers are leaving at alarming rates. But as we've seen and learned from with COVID and other disasters, I will say, because we haven't had other pandemics, fortunately, recently, but other disasters is that our preparedness teams across the city, the county, and the state are ready, and the plans are in place that should we need to partner with our neighboring counties and states, we're ready to do that to make sure that we have all hands on deck to support the community. But it is true that our local healthcare workers, just like across the country, have left us at alarming rates. But we have seen as well that we're able to rise to the challenge.
Okay, a report from the Baker Institute mentioned that anti-vaccine legislation can pose a threat even when not passed. Texas 2021 legislation proposed unsuccessful anti-vaccination, and speculation shows that it might be submitted in 2023. That is true.
Yeah, so look, we're about out of time, so I'm not going to go to my soapbox, but this is just foolishness. Anti-vaccination legislation, politicians should not be making medical decisions. This is or quite honestly, public health, in my opinion. Anyways, I got a soapbox, but we haven't got enough time.
We should trust our medical professionals. And I think y'all have certainly passed the test today. Thank you for joining us for COVID-19 Talk with Local Health Authorities. With us was Dr. Erica Brown, representing Harris County, Dr. David Pearce, representing the City of Houston. Special thanks to past president of Rotary Club of Houston, Kathy Finninger. Our producers, David Castillo, Priscilla Key. I'm Stephen Williams, Director of the Houston Health Department.